going to talk about addiction assessment. Are you going to be able to advance my slides there, David?
Absolutely.
Great, thank you. So you can go to the next one. So I don't have any disclosures. So I'm going to talk about the importance of addiction in the context of pain treatment. Also review again the DSM-5 definition of addiction and some of the changes that happened with DSM-4. So and how they're relevant for pain treatment. And then talk a little bit about monitoring and aberrant behaviors during pain treatment that may be signs of addiction, and then how to respond to those, at least in order to suss out whether addiction may be a major issue. Next slide. So why is it important? I think there's been so much recently in the news. Maybe this isn't necessary to say, but I'll just say that safety is really how I think about the importance of addiction and substance use and aberrant behaviors related to opioid prescribing. Most of the overdose deaths actually that involve opioids do involve multiple substances. So it's not usually just the pain patient who is prescribed medication, but but someone who's involved in non-medical use of opioids and potentially other drugs as well. So I think in deaths with opioid overdose, there's a mean of 4 or 5 other substances involved. Pain treatment with opioids is not going to work in the setting of an active addiction. I'd say pain treatment with anything is not going to be that effective, and really ends up sort of overwhelming the mental health, other issues that people have. And until the addiction is dealt with and stabilized, you're not going to be able to get much progress in the other realms. Addiction is also important as a risk factor for problems with opioid prescribing. It's probably the one major risk factor that does cut across multiple studies looking at it in many different ways. Additionally, addiction to opioids or addiction to other substances in conjunction with opioids often does require some kind of specialized treatment. That doesn't mean it necessarily has to be outside primary care, but some kind of treatment from and consistency around management of the addiction. And that is not always easy for patients to access. And then I guess lastly on the list is the prescribing opioids when patients are active in their addiction. Those are the kind of patients that do come to the attention of law enforcement, potentially the DEA, and I think has led in cases to physicians having their pain management practices reviewed adversely. Next slide. So this is the slide of what's the difference between being addicted to painkillers and just really, really liking them a lot. And that's more the diagnostic question that still remains kind of hard to answer, actually, when we have patients who come in reporting pain, looking like they may have an addiction problem or having a history of it, and sorting out how do I define addiction in this kind of setting. Next slide. So this is the DSM kind of, and the things that are different is now there's something called addictive disorders in the DSM. They didn't have that before. They had substance abuse and dependence, but now addiction has made its return. So it's a cluster of cognitive, behavioral, and physiologic symptoms indicating that the individual continues to use substance despite significant problems, substance-related problems. It does involve brain changes that are increasingly clarified with our new neuroscience, but these changes do persist even after people stop using, and they are associated with craving and relapse. And so the new definitions with DSM-5 were really trying to understand some of the problems with DSM-4 around trying to just terminology around substance dependence, physical dependence. What's the difference? That's pretty confusing when your diagnosis is substance dependence, but one of the manifestations may be physical dependence, a different concept. And then really there wasn't much evidence that abuse and dependence are different disorders, more that they are a continuum, and then there's no way to factor in physical dependence on prescribed medication. That was not something that DSM-4 tried to deal with. And then there wasn't any severity specification around addictive disorders. Next slide. So the major changes, really changing the terminology. So there's no longer substance abuse and substance dependence, but this single substance use disorder diagnosis. And it does have a new criteria, which is craving, a new severity estimation. So you can have mild, moderate, or severe and then there's new exclusion of tolerance and withdrawal symptoms as describing DSM-5 substance use disorder if those medicines are prescribed, and we'll talk a little bit more about that. Next slide. So here are the criteria. I don't really, I think they're probably in my brain and I could spew them out, but I don't really look at this as a checklist kind of diagnosis, but there are 11, and tolerance and withdrawal are included, but if the with the exception of prescribed medications if they're taken as directed. And then there used to be an abuse criteria that had to do with legal problems, but that's no longer part of DSM. And then the craving criteria is new. The others are all the same, just combining abuse and dependence criteria. Next slide. So there's also a new severity estimation with if you have one criteria or none, you don't get a substance use disorder diagnosis. And then you can see mild, moderate to severe with more and more criteria. Moderate and severe are thought to be comparable to substance dependence in DSM-4. So lots of the studies that look at medications or other interventions for substance dependence, you can think of that as moderate to severe substance use disorder. And then the exclusion of tolerance and withdrawal applies to appropriate medical treatment with prescribed medications, and with the caveat that individuals whose only symptoms are those that occur as the result of medical treatment. Just tolerance and withdrawal that you might even have with like clonidine for blood pressure control or beta blockers, those kind of even meds that we don't consider abusable. Or if it's only in that kind of context, then you should not receive a diagnosis of a substance use disorder. But if you meet some of the other criteria, you do have craving, or you do have a desire to cut down or quit is a pretty common one, then then these criteria do apply in your severity estimation and in the diagnosis of substance use disorder. Next slide. So there are a lot of tools to try and use, and I think in our telehealth program, we always talk about the opioid risk tool. This is what it is, and really, and we try and figure out for patients who either are on opiates or hopefully before we start, what kind of risk people have. And I don't know that this is a magic tool. There's lots of other tools that have been developed, but the personal history of substance abuse or having an addiction is whether it's certainly when it's active, but even in the past, seems to be the one that really carries through a lot of the other tools as well. Family history is really important. I think it's pretty rare that I see a patient with an opioid use disorder diagnosis who's actually coming to treatment who doesn't have a family history. It's just very genetically loaded. So, and then you can see the other criteria for risk that we use, and you try and rate that, but a lot of times you don't really have clear, either using DSM-5 or opioid risk tool, you're facing some uncertainty as to what's going on with the patient. Next slide. So I just want to talk about getting an addiction history, because I think it's an important skill for primary care docs to have, for pain docs to have, and it's I think can be very challenging in the setting of a patient coming and asking for opioid medications. They may be quite defensive. So really, I think the most important thing is to try and establish rapport through understanding the pain story that the patient has. And I think if you really listen to that pain story, there are many clues in the pain story that will either make it clear that there is a lot of risk there or not. But really, how do you listen to a pain story? You have to reflect aspects of their story that you want to hear more about. And you want to be interested, attentive, leaning into the patient rather than retreating to the medical record, or with your body language, making it clear that you are really uncomfortable with pain stories. So that's a big topic in itself. But mostly in terms of screening patients, there's a lot of work around like a universal primary care screening for alcohol and drug problems. How often do you binge drink would be a question, and that's not the way you word it. It's how often do you have more than 5 or more drinks if you're a man, 4 or more drinks if you're a woman, and using that as a screen. I don't usually use that in patients that I'm needing to get a little more information about, but it's recommended, especially for alcohol, and there's a lot of evidence that it's useful in primary care, but that's a different topic. For people who do have a positive screen, or for me, I just ask almost everybody, just tell me about your drug and alcohol use. I think tell me about questions are the best ones, and whatever they say, I'm trying to think about, are they telling me criteria that might fit DSM-5 symptoms? And then I'm also just trying to reflect their concerns that they might have currently, or more likely in the past, because addiction is really an adolescent onset disorder in many cases, and there will be potentially a lot more information you can discern from their adolescence than you can from their current situation. And that empathetic kind of conversation around, I consider drug or alcohol addiction to be a medical problem, not a moral failing. Those kind of terms can sometimes turn conversations towards a more supportive stance. And you can use the DSM if you need to. Go ahead. You can go ahead and switch. So I do ask about the past a lot for the reasons I mentioned. It's less threatening. You can often get a diagnosis that way, at least a lifetime diagnosis of an addiction, which is the main risk factor for problems with opioid prescribing. And you can also start to develop some rapport. So if you can listen for comments about a patient trying to receive care or being treated poorly in the medical setting because of their addiction or the stigma around that, or having problems accessing treatment for addiction in a way that they felt comfortable with, you should definitely listen for that and then reflect, meaning so it sounds like you had a problem with that doctor when you disclosed that you had a problem with alcohol in the past, and really trying to get that patient to talk more about that. And I think that kind of, if you get those stories and tell people that they feel, how hard that must be for them, you really start to get a rapport that I think is much more likely to get the real story out. And certainly if patients have severe problems in the past, there's usually a recovery story. It's not always that easy to stop. And so look for that and reflect on it and give people support for those stories. Next slide. So if patients who are on opioids, and I think increasingly it's not so much a question of are we going to put the person on long-term opioids, because we're, especially at high doses, are really avoiding that a lot. But there are still a lot of patients out there who are on long-term opioids, and we do need to be vigilant in making sure that that's safe. So we do need to monitor patients. That does include urine testing. I think most practices are doing that now. And then the prescription monitoring program checks to make sure that the prescribing is safe and not being duplicated elsewhere is important. I do think that the intensity of that monitoring can reflect the risk of the patient, and you're concerned about the possibility of safety issues, and really framing it as trying to make sure that this is safe. And I think for folks who have some kind of recovery history, supporting that recovery is really important, and it can be actually something that you're doing for the patient, not just for your practice or the policies around your practice. And then just recognize that you might not get it, the patient might not get it, may not realize this extent to which they have problems with control over these medications. And so the current addiction problems can come up over time, not necessarily right in your face that first time you meet them. Next slide. So these are some aberrant behaviors that we talk about quite a bit in the pain setting: early refills, running out early, not talking, trying to increase the dose on their own because they have more pain without talking to you. The urine toxicology results, understanding that urine toxicology testing is not a perfect science, so we do get a fair number of false positive or false negative kinds of results, but that may be something that you need to respond. I mean, you do need to respond to it, whether it turns out to be a true thing or not. And then behavioral problems noted by staff. So the front desk is your friend, and if you're getting words that there's a lot of commotion out there, or a lot of people are, the patient isn't treating other staff well, even if they're treating you as a prescriber well, I think that's an aberrant behavior in my book, and in fact an important one, both for your staff, for your team, and for you to really be supportive of your staff. It's really important to address those kinds of problems. And then if the PMP shows something that's unexpected, or even if the patient isn't adherent to the treatment plan for their pain, their mental health, their other medical issues, that is a type of aberrant behavior. Not that it's going to mean that you have to immediately stop prescribing, but it's more of a conversation starter, or a starter in terms of you're thinking about what's the differential diagnosis of this aberrant behavior. Next slide. So responding to these kinds of behaviors, obviously safety is the main thing, because we don't see these patients very often. It's when they're in the office. So there is the phenomenon of, oh my gosh, there's really a lot going on and I didn't realize it, the tip of the iceberg issue. And then there may be something new going on that is important to understand for your patient. Maybe it's even a new diagnosis, whether that's mental health or addiction. Diversion is always on our mind and really tough to sort out often, but I think most commonly when there's aberrant behavior, there's some kind of stress going on, and just getting to that. It's kind of similar to, doc, my pain's not being controlled. It was for a long time, but it's not right now. Maybe I need more medication. Or maybe they've had a new social stress, and I think it's very rare that pain flares without some kind of social stress, or potentially worsening of a mental health issue, potentially an addiction problem going on. That's what you got to think about and sort out. Ignoring these kinds of signs of these aberrant behaviors is not good for the patient, not good for the provider, not good for the clinic. So it's important to follow up on these. And then you can also overreact. They missed their 1 out of their 5 PT appointments, and you're worried about whether you're prescribing appropriately. That may not be necessary, but and then the patient can suffer on that basis. Next slide. So what do you do? I mean, I think prompt response, although at Harborview these days we get so many urine test results that are false positive, we kind of can't respond completely promptly. You have to wait for the confirmatory tests. I don't know if they're having that problem over at the university, but we're having a lot of that. So as promptly as you can, trying to respond to a confirmed positive test, potentially asking the patient to come in for another test, potentially bringing their medications so that you can make sure they have them. I think that doesn't, even if they do have them and their urine test is okay, that doesn't mean that you're necessarily, there's no issue, but it's certainly reassuring if they still have their medication and there isn't a consistent positive test. And then just discussing the behavior and what your concerns are, whether they're about safety or about just that their pain treatment isn't going the way that you had agreed. And the patient's response to this can be very helpful if you're being just straightforward about what, this is what we thought was going to happen and this is what happened, trying to figure out what's going on in terms of that stress or that new diagnosis, or is this a really defensive and vague patient that I'm going to be more worried about, or do they potentially have misperceptions about their pain treatment, about their pain medication, and not really understanding the importance of sticking with the plan. Next slide. So increasing treatment intensity is a pretty common strategy that we use, especially since you are likely to find some new issue that's gone on, whether that's something that requires a referral for mental health or other testing or closer follow-up. I think you have to take these aberrant behaviors as kind of like you might take some kind of worsening renal dysfunction that's unusually severe, or a patient who comes in with heart failure and their legs are all of a sudden swollen and their oxygen not so good. You may not have to hospitalize, but you're going to have to do something, and that's usually includes seeing them back soon, making changes and following up. In the case of pain, we're talking about reinvigorating the behavioral changes that they may have made and then lost track of because of the stress that they had in their life or the job that they lost, and trying to get that together, and then trying to trying to get more information by seeing their response to that increase in treatment intensity. So obviously this can get complicated, and a lot of the cases that we hear in TelePain are when it's gotten complicated or you're struggling, and I think having team in place, whether it's through TelePain or something connected to your clinic or your favorite expert that you call, all those are methods to get some help and get the support you need, because this can be really stressful. Next slide. So keeping it safe is obviously so you may have to do something quickly if safety is an issue. The patient shows up with an overdose in the ER. Obviously that's something that a good opportunity to not give them as much and making sure that they're safe. And then, missing an appointment might be a concern, but not necessarily something that needs immediate action. Lower doses are safer, and so for patients on high doses, this is even more of an urgent thing to make sure that we're being safe. And if you do have problems that are related to addiction, you may not be able to handle them all in your setting, but hopefully you will be able to handle more of them as time goes on, and as if they do need addiction treatment, potentially even being able to provide that in your practice, or a practice that or a provider within your practice who can prescribe medication for opiate addiction can be very helpful. Next slide. So stopping prescribed opioids, I think there's a range here about when to do that. If you have patients that there are some aberrant behaviors that you might not have to stop. You might want to lower, or you may just continue with your regular prescribing if you have low doses. And then some settings don't require any taper, like if patients are only on a low dose, you may be able to stop. If there's diversion, you call them back for their medication, they don't have any medication, then they obviously are not always taking their medication, and so stopping is not necessarily a safety problem in itself. It's those patients on higher doses where stopping can be a dangerous thing, and can be something that you may need to consider transferring a patient to some form of opioid addiction treatment, either with buprenorphine or methadone. I think generally it's good to get help with this kind of patient. telling somebody I can't prescribe anymore, going from a high dose to zero without any kind of help or support for the patient getting to an alternative form of treatment is definitely putting them at risk, and I think is not the best practice. Team approach, clearly the best here. You want to share the wealth and share the problems that can arise in this setting. Next slide. So here a lot of patients talk about they got fired when really what happened was their opioids were stopped. But I still need to plead for you not to fire your patient, even if you do have to stop prescribing opioids. If there is an opioid addiction, you may or may not be able to provide that addiction treatment in your setting, but the patient needs it, and it doesn't mean that you have to stop caring for the patient in terms of their other medical issues or even their chronic pain, although you may very much need the addiction to be stabilized before you can do much about that chronic pain. It's really remarkable to me seeing patients who are really hard pain patients. Once that addiction is identified and treated, come back, and there's a lot more that you can do, and it's a lot easier in that setting. So don't fire them, be supportive. This is a medical problem. You may not be able to manage it yourself, just like you may not be able to manage the very severe heart failure patient. You may need help from a cardiologist for that patient, but it doesn't mean that you're firing the patient or saying that they can't come back or treat their other problems. So next slide. So this is just the summary slide. Addiction is important in pain treatment. The diagnostic tools we have, even the new ones with DSM, can be limited, and we may not get an answer immediately around what making an addiction diagnosis, monitoring and responding to the behaviors that can be problematic in the setting of pain treatment can help us understand and identify addiction problems more readily, and make sure you get your patient's addiction treatment with methadone or buprenorphine if they need it. That's the end of my talk.